Hi, my name is Linda Norix, and I am a pediatric audiologist in the University of Arizona Department of Speech, Language, and Hearing Sciences. Today, I will be presenting part 2 of a series of videos on childhood hearing loss. This educational training video is the second of a series of videos on early childhood hearing loss made possible by funding from the Arizona Department of Health Services. In video 1 of this series, you learned about the Early Hearing Detection and Intervention Program, also known as EHDI. You learned that the purpose of EHDI is to identify the presence of hearing loss as early as possible to reduce the risk of developmental delays. You also learned that when a newborn or infant refers on a hearing screening, follow-up diagnostic testing should be performed by an audiologist by 3 months of age. In this part of the series, you will learn about the comprehensive audiologic assessment. I will discuss what happens after a baby refers on a newborn hearing screen. You will also learn about the role of the audiologist in the EHDI program. You'll learn about the comprehensive test battery and the types and degrees of hearing loss. The role of the audiologist in the EHDI process is to diagnose the presence of hearing loss by 3 months of age. The audiologist does this by providing a comprehensive audiologic assessment to determine the degree and type of hearing loss. The audiologist will refer for and participate in follow-up procedures when a permanent hearing loss is confirmed. A refer on a newborn hearing screen is not a diagnosis of hearing loss, but indicates that the child is at risk for having hearing loss. Children who refer require a comprehensive audiologic assessment. This assessment is required because abnormal function in different parts of the ear can cause hearing loss. The parts of the auditory system are generally described as the outer ear, the middle ear, the inner ear, which contains the cochlea, and the auditory nervous system. This is a picture of the 4 parts of the ear. The outer ear includes the pinna, which is the visible part of the ear, and the ear canal. The middle ear is the air-filled cavity with 3 bones that carry sound vibrations from the eardrum to the inner ear. This is the inner ear, where the organ of hearing changes sound into electrical signals that are carried by the auditory nervous system to the brain. The types of hearing loss can be divided into conductive and sensorineural. Conductive hearing loss occurs when there is a problem in the ear canal or the middle ear. Sensorineural hearing loss occurs when there is damage in the cochlea and/or the auditory nervous system. Conductive hearing loss can occur when there is damage or malformation of the outer or middle ear. Conductive hearing loss can also occur when there is blockage of the ear canal, for example, earwax, or when there is fluid in the middle ear. A conductive hearing loss may be corrected with medicine or surgery. A sensorineural hearing loss occurs when there is damage or malformation of the inner ear, usually the cochlea. This type of hearing loss is not surgically or medically reversible, but can be treated using hearing aids and/or cochlear implants. You will hear more about hearing aids and cochlear implants in part 3 of this series. To determine the type of hearing loss, the audiologist uses a collection or battery of tests to identify the site or sites of dysfunction within the auditory system. The function of each part of the ear can be evaluated while the infant is quiet or asleep. The outer ear is evaluated using otoscopy. This is a picture of an eardrum, which is what an audiologist will see if there is no earwax and a clear path for the sound. The middle ear is evaluated using tympanometry. Tympanometry will tell us if the eardrum is vibrating and whether it is sending the signal from the middle ear to the inner ear. The inner ear is evaluated using evoked otoacoustic emissions. Remember from part 1 of this series that EOAEs are sounds generated within a healthy inner ear, and they can be measured by placing a small probe in the ear canal of the infant. Although EOAEs provide no information about the degree of hearing loss, they are an important part of our test battery. EOAEs should be present if the inner ear is healthy, provided there is a clear ear canal and a normal middle ear. The auditory nervous system is evaluated using the Diagnostic Auditory Brainstem Response Test. This test is also known as the BAIR, or the Brainstem Auditory Evoked Response. The diagnostic ABR uses the same principles as the automated ABR that is used for screening. That is, electrical activity from the brain is recorded by placing small electrodes on the child's head. In contrast to the AABR, which provides a pass or a refer, the diagnostic ABR determines the amount of hearing loss for different tones. Here is an example of a response from the auditory nerve. The top trace is a response to a very loud tone. Because there is a response, we know that the child can hear that tone at that level. The bottom trace shows no ABR response. Because there is no response, we know that the child has hearing loss and is unable to hear that tone at that level. The results of the ABR are plotted for each ear on a graph called an audiogram. The audiogram is a graph of the softest sounds that a child can hear. Loudness is plotted from top to bottom, with 0 being a very soft sound and 120 being a very loud sound. Pitch is plotted from left to right, with 125 being a very low pitch. Think about the low keys on the piano. And 8,000 being a very high pitch. Think about the high keys on the piano. If the results of the ABR are plotted at 20 or better, the child's hearing falls in the normal hearing range. Where the symbols are plotted indicates the amount of hearing loss. In this example, the child has a mild to moderate hearing loss. Many of the high-pitched consonants that are important for understanding speech will be difficult for this child to hear. Note that the child can hear some sounds and may seem to hear normally when he or she actually does not hear well enough to develop age-appropriate speech and language. The degrees of hearing loss can have an impact on speech audibility. For example, a child with a mild hearing loss may hear some speech sounds, but soft sounds will be difficult to hear. A child with a moderate hearing loss may hear almost no speech when another person is talking at a normal level. With a severe loss, the child will hear no speech when a person is talking at a normal level and will only hear some loud sounds. With a profound loss, the child will not hear any speech and will only hear very loud sounds. Once diagnosed with hearing loss, early intervention can be initiated. If initiated by 6 months of age, it will lay the foundation for speech, language, and auditory skills development. Can you answer these questions? By what age should an infant who refers on a newborn hearing screen have a diagnostic hearing evaluation? The answer, by 3 months. Next, what part of the ear is damaged when there is a sensorineural hearing loss? The answer is the inner ear and/or the auditory nervous system. How much conversational speech would a child with a moderate hearing loss hear? With a moderate hearing loss, a child will hear almost no normal level speech. Finally, what is graphed on an audiogram? The audiogram displays the softest sounds that a child can hear. Thank you for viewing this video today. In part 3 of the series, you will learn more about the early hearing detection and intervention program. Specifically, you will learn more about the intervention services that a child and his or her family will receive once hearing loss is identified.